And now I invite Dr. Naren Shetty, and he is a very good surgeon, excellent surgeon for phaco, LASIK, smile, and all other things. And he has completed his PhD also. Let us hear from him his experience with the pure refractive lens in India. Over to you, Dr. Naren.
Good afternoon, everyone. On this onset, I would like to thank J&J for giving me this opportunity. These are my financial disclosures. Now, let's dive in directly to our clinics. What is a situation where we choose a non-diffractive EDOF over a trifocal or a diffractive or a diffractive IOL? It is situations where either the eye is a non-pristine eye, where already there's some problem going on in the eye and you don't want to compromise in quality. The second thing is where patient already is wanting no glare, no halos, and he's very concerned about his visual quality. So just to summarize, he wants the best quality vision, but he wants a presbyopic option, right? When you're talking about best quality, this is where the POC really comes into picture. It is a purely refractive. When you look at the surface of the lens, you can't make out the difference. And forget about the rings, you don't even have any bumps on the surface. And when you look at all the publications currently on this particular lens, it's comparing to a monofocal. Why? That is the quality of quality it's actually delivering. It's very comparable to a monofocal IOL. So this is our experience with the POC. We have done over 60 cases. But before I share that, we need to understand one concept, something called as, these EDOFs have something called as landing zone. And when I say landing zone, that means anywhere if my power falls between plus 0.5 to minus 0.5, I will still have 20/20 vision. Now the question is, how do I refract this patient? If I refract it to 0, it's 20/20. If I leave a little plus 0.5, it's 20/20. So I don't know what to do, right? So we have to remember this concept as maximum plus refraction in these patients. So that means we are trying to push the defocus as much as possible so that we explore or exploit the entire potential of the lens. So basically when you maximize it, you shift it. You can see this, you can shift it. So automatically your near and intermediate improves. So whenever you refract EDOF IOLs, just keep that in mind, maximum plus. So anyway, this is our 3 months post-op data. And at that point, actually, there was no toric lenses. Even so, if you look at the unaided vision, 90% of the patients were 6/6 or better bilaterally. And 100% of the patients were 6 by 7.5 or better. So which shows that how much tolerance it has to residual error, even though we didn't use any toric lens. Next is, this is best corrected distance vision, monocular vision. About 5% of the eyes had some amount of amblyopia. But if you look at the same set of patients, binocularly, 100% of the patients were 6/6 or better, and 31.6% of the patients were 6 by 5. See how beautiful the binocular vision is, even though the 5% of the eyes had some amount of amblyopia. Now, when we come to intermediate vision, 57.9% of the patients had 6 by 7.5 or better, and less than 6.9, about 100% of the patients were performing really good in terms of the intermediate. When we come to near, 100% of the patients were N8 or less, and 57.9 again were N6 for near. So they did really well at different distances, and this is how the defocus curve is. And it's very similar to Symphony, but near vision a little bit better than the Symphony, but none of those side effects which Symphony had. Anyway, in terms of the quality, the point spread functions, MTF does really well. We have got the median of MTF value of 0.33, which is better than any other EDOFs right now in the market. And when we look at the visual quality questionnaire, it is very similar to that of a monofocal. As already mentioned, we also had a similar kind of results. And I want to share my first 2 cases of the POC. All right. So this is a 70-year-old male patient who was very keen on a presbyopic option, but he was very, very particular that he wanted good quality too. And again, here we went ahead with the first minus, that is minus 0.33 in one eye and minus 0.38 in the other eye. So when we look at the results, the distance uncorrected vision were 20/20 for both eyes. The distance corrected vision were bilaterally was 20/16. Intermediate unaided was 20/25. Distance corrected intermediate was 20/20. And the near vision, both both uncorrected and distance corrected vision is N8. When I say distance corrected, again, please remember that is the maximum plus. So visual quality, you can see how good the MTF value is, and also the point spread function, it's fantastic. This is case 2, again, a businessman who was, actually used to drive a lot, so he was very concerned that he didn't want too much glare halos, but wanted good quality vision for intermediate and near 2. And here again, we went ahead with minus basically the first minus, that is minus 0.34 in one eye, the other eye was minus 0.29. And here you can see the patient was uncorrected 20/20 for both eyes, distance corrected was 20/20. For intermediate, uncorrected and distance corrected were 20/20, and even the near was uncorrected and distance corrected was N6. Basically, patient was perfect at all distances. Again, excellent visual quality too. But enough of all this now. When we talk about presbyopic IOLs, we have so many lenses in the market. It becomes really challenging. Forget about patients. We doctors itself to understand and explain all this becomes practically impossible. So this is how I divide my lenses into diffractive and a non-diffractive. Keeps it so much more simpler, and it's easier to counsel the patient. Now, but how do we choose which eye we choose a diffractive and which eye we choose a non-diffractive? This is how my decision tree is. So if a patient wants a presbyopic option, first I see if the patient is suitable for a diffractive IOL. And this is a simple criteria which we follow. And if the patient is suitable for a diffractive IOL and a patient is not a type A personality or not a negative character, then we go ahead with a diffractive IOL like Synergy or any other diffractive IOL. But if the patient is a type A or a very negative personality, then you push towards a non-diffractive IOL like the PCIOL, which is, as you know, as you've seen the data from all three speakers, it behaves so much like a monofocal. Now, if it's not suitable for a diffractive IOL, you can either regularize the cornea so that it becomes more regular, and then you can go with the diffractive, or you don't do anything, just go ahead with the non-diffractive. So this is a simple decision tree which really helps you to decide which patient gets what, and the patient also is easy to comprehend too. Now, if we are one of the people who haven't started presbyopic IOL and we want to start something, then POC is the lens for it, because to do a workup for this lens is just like how you do a normal workup with a monofocal. It behaves like that. And the dysphotosphere profile also is very similar to a monofocal. And plus, you don't need to look at all these parameters, pupil size and high order aberrations and motive. All these things you don't need to look at. So it's a very easy lens. You can actually start off today itself. If you're implanting monofocal, this is something that you can easily change over, and it's a very forgiving lens, and believe me, patients are always happy. And then I would like to invite everyone for our conference in 2025, July 18th and 20th in Bangalore. This is one, it's a single place where you can get anything and everything about cataract refractive, from your wet labs. You can actually do your lenticular procedures, everything. It's all in one roof. Thank you so much for your time.